Sir, we are starting in 3, 2, 1. We, we are now online.
So, once again, a very warm welcome and good evening to everyone for this Clinical Oncology Updates 2026 Day 2. And as I always maintain it said, so we have the young and dynamic convener, Dr. Pulkit Nag, consultant medical oncology at Apex Hospital, Jaipur. So we carry the greetings from the Pink City once again. Good evening. And Dr. Pulkit sir, welcome to you for the day two. I request you to start the proceeding and invite the chairpersons for the further proceedings, please. Over to you, sir.
Thank you, Tarunji, and thank you to the organizing team. So we are on the day two of the webinar. Yesterday we have discussed the breast and the lung session, and today we are going to discuss the GI and GU session. I welcome you all, and I especially welcome Dr. Deepak Gupta sir and Dr. Aditi Mittal ma'am, and who are the chairperson for the first GI GU session. And over to you, Deepak Gupta sir, for the further proceedings. Sir.
Thank you, Pulkit, for
Thank you,
inviting me today to chair this session, and thank you, organizers. So, we'll start the session now. So, first session is by Dr. Pulkit himself. So, he
Yes,
is
sir.
consultant medical oncology at Apex Hospital, and he will be speaking on role of avelumab in renal cell carcinoma. To you, Pulkit.
Yeah. Organizing team, I'm going to share my own slide.
Yes, sir.
So I think I'm not able to share. Yeah, now I can. Is it visible?
Yes, sir,
Yeah.
visible.
Okay. So I'm going to discuss, it is a sponsored session by Merck, and I'm going to discuss the role of avelumab in advanced RCC. So some disease background on RCC. We all know the new drugs and the mechanism of action in RCC. We start with lenvatinib, which has multiple actions of FGFR, anti-PDGFR, and VEGFR. We have anti-VEGF drugs like sunitinib, axitinib, pazopanib, and other TKIs. We have anti-VEGF like bevacizumab. We have anti-MET inhibitor, anti-AXL inhibitor like cabozantinib. Now we have a lot of immunotherapy options available in the form of pembrolizumab, nivolumab, which are anti-PD-1. We have atezolizumab and evolumab. We have anti-CTLA-4, that is ipilimumab, and the newest thing we have is CAR T cell therapy. So I think all these drugs leads to a mechanism cascade via PI3K, AKT, and mTOR pathway, which ultimately leads to cell growth, survival, angiogenesis, and migration. Also, now we have belzutifan, which is an anti-hypoxia-induced factor drug, which is also responsible for this factor responsible for cell growth, survival, and angiogenesis. So by blocking the VHL receptor, we are directly affecting the intranuclear growth of RCC. So these are the cascade of drugs available for RCC. So if you look at the evolving field for the first line metastatic RCC, the IO combinations change the therapy landscape. Up to 2005, we have interferon alpha, then we have interleukins, then we have TKIs, and now from 2017 to 2022, we have combination of IO plus TKI in the form of various trials like Checkmate, Keynote, Javelin, Checkmate 9ER, that is, and Pembro plus Dinva Clear trial. And then we have combination of 2 IO plus cabozantinib 2022, that is a triplet, Checkmate 313. Also, now we have a dual IO, that is Nivo plus IPLI. So we're going to discuss about the Javelin Renal 101, which is a phase 3 trial study with the longest follow-up. It is a phase 3 trial study of IO plus TKI with the longest follow-up in the first-line treatment of patients with advanced RCC. And the key eligibility criteria is previously treated advanced RCC with clear cell component. And it is randomized into avelumab 10 mg per kg with axitinib oral twice daily. And the comparative arm was sunitinib. So the follow-up of Javelin Renal 101 trial is around 73.71, which is the longest. We can see in the downwards, and rest is 67, 55, and 49 months. So the longest follow-up is for the Javelin Renal 101. So how does the combination of avelumab and axitinib help in battling RCC? So Bavencio has shown to release the suppression of T cell mediated anti-tumor immune response by blocking the interaction of PD-1 and PD-1 receptors. Beventio has also been shown to induce NK cell mediated direct tumor cell lysis by ADCC, and exitinib, on other hand, acts on VEGF receptor 1, 2, and 3, which are important in pathologic angiogenesis and lymphanogenesis. And the increased expression of VEGF also leads to increased tumor antigen, which indirectly leads to the increased expression of PDL1 receptors and indirectly supports the complementary supportive mechanism of IO. So this is how the dual mechanism of IO and TKI helps in battling the RCC. Regarding the benefit of response, so the median PFS benefit was with 34.4% reduction and almost double ORR compared to sunitinib. So this was we can clearly see the separation of the curve, 13.9 versus 8.5 months. The longest follow-up was 73.7 months in the median OS. In the combination of IO plus TKI, it is 44 versus 38 months. And we can even see that till 5 years, that is 60 months, the response is 37 versus 33%. So on the longer follow-up, the final OS readouts will better reflect the effects of later line. This has been observed for all phase 3 first line IO plus TKI. And due to these factors, median PFS and ORR remain important relevant endpoints. A high proportion of patients in sunitinib arm. So if we compare, like this diagram shows that if the patient has received initially avelumab plus axitinib, that is the blue color bar, and if the patient has received initially sunitinib, so we can clearly see that if patient has initially received only TKI, that is the red color bar, the chances of subsequent treatment is very high. And after IO plus TKI, the blue color bar is lesser, is shorter, which shows that the response is more sustained and effective, and there are lesser chances of subsequent treatment in both in favorable risk, intermediate risk, as well as in poor risk. Also, the real world studies have confirmed the effectiveness and the safety of first line avelumab plus axitinib. So the observation studies ORR with a combination CR rates from 4 to 15%, PFS was 13.5 months, and the real world JDART2 study, which is done in Japan, the median PFS was 17.1 month, which is in concordance with uh, the Javelin trial. Also in UK study, the response remains the same. So even the real world study done in Japan and UK indicates that the results of Javelin trial is supported by it. So avelumab plus axitinib has a well-characterized safety and tolerability profile with a lower rate of discontinuation due to treatment-related adverse effect. So also a high-dose glucocorticoid greater than 40 mg daily dose of prednisolone were administered because of infusion-related adverse effect in 14.5% of the patient treated with avelumab plus axitinib. So the grade 3 reactions are less, and there are lesser use of corticosteroid if we compare to other IO agents used. So these are the treatment-related effects. We know that the diarrhea and the fatigue and hand-foot syndrome are the classical side effects of TKI, and stomatitis and hypothyroidism are the classical side. The hypothyroidism and the glucose and the hypothyroidism are the classical side effects of immunotherapy. So advanced renal cell carcinoma is a cluttered space, and choosing the right therapy for right patient is important. So we have various, as we have discussed, we have a various combination uh, available with us, and what to choose depend on lot of status, a lot of other characteristic. So if we see and compare the various first line IO combination trial from checkmate to clear to javelin, we can see that the landmark overall survival was almost same in the range of 85 to 90. The only difference is the longest follow-up was in javelin renal trial. Also in checkmate 214 in dual IO, the follow-up is larger, but the indication of dual IO is not in every risk profile patient. So we can clearly see in the overlapping of the arm in RCC with IO plus TKI, so we need to have an individualized approach to offer the maximal benefit. So first line treatment depends on various factors. The most important is the risk category, that is IMDCC risk grouping, then biology, treatment related effects, dosing, site of disease, quality of life, what are the PFS and OS benefit, what does the guideline suggest, and what is the patient choice, the most important thing. So, like not every combination work equally in all three risk categories, whether it's favorable, intermediate, or poor risk. So let's see in which risk category what does the role of various IO-TKI combination. So in a summary, in advanced RCC, one size doesn't fit all. So first we're going to discuss about favorable risk RCC. If we look about apart from Javelin trial, all the other trials in IO plus TKI, there was an unclear OS benefit seen uh, in IMDCC favorable risk patient. Wherever the favorable IMD series group shows benefit when treated with IO plus TKI to TKI alone. So this is for sure that we need to combine the IO plus TKI in comparison with TKI alone, but we need to figure it out that which TKI has worked the benefit. So the OS and PFS benefit seen in favorable IMD series group with avelumab and exitinib was shown the clear separation of the curve, which was not seen in the combination of other IO and TKI in favorable risk group. And also there was a 40% reduction of risk of disease progression or death. So this is again the comparison we have previously seen, and the best hazard ratio is seen in Javelin Renal 101 trial. If we look at the poor risk category, combination, we have clearly seen the median OS benefit was more larger in 21.3 versus 11 month, and we can clearly see the separation of Kaplan-Meier curve. This we have already discussed. So the first Indian real-world data of Bavencio plus exitinib, and it has shown that in favorable risk group, the response rate was 100%. In intermediate, it was 61.5%, and in poor risk group, it is 52.2%. So, on the basis of risk group, the sustained efficacy across all the three risk categories, reinforcing the regimen's broader clinical acceptability. So that is the edge point of combining Bavencio with exitinib. So this is the just a crux showing that in favorable risk, avelumab plus exitinib has a dominance, whereas we talk about in poor risk or intermediate, any of the combination can work. We have to choose as per the patient comorbidity, as per the affordability, as well as the important role is which TKI to be chosen. So yeah, so next question is we have a lot of TKI available. So how to choose which TKI with which I? So if we talk about the half-life and the rapid clearance, the axitinib had the shortest half-life, and a short life and a rapid clearance supports the management of therapy. So it reaches a stable level in blood within 2 to 3 days, that is axitinib, and due to shorter half-life, the plasma concentration rapidly decreases following treatment interruption, which supports therapy management of IO plus TKI combination therapy. And this we have already discussed that there are classical side effects of TKI, that is hypertension, fatigue, and HFS. And with checkpoint immune inhibitor, we have colitis, hypophysitis, pneumonitis, and infusion reaction. And hepatitis, diarrhea, thyroidism, arthritis, and rash can be seen both in TKI as well as in checkpoint inhibitor. So deciding between exitinib-based combination, exitinib avelumab or exitinib pembrolizumab, we need to check the toxicity as well as the efficacy as well as the risk stratification. So if we do a head-on-head comparison, the median follow-up is longest with Bavencio and exitinib. Percentage of favorable risk group is 23 versus 32. Median PFS benefit versus sunitinib is 5.4, higher in Bavencio plus exitinib. Median OS is 5.9 versus 6.4, and the discontinuation rate was lesser in Bavencio plus exitinib, and also the pneumonitis rate was pretty less in Bavencio plus exitinib, and steroid use was also lesser in Bavencio plus exitinib. So in advanced RCC, patients are living longer, hence safety and quality of life is important for overall quality survival. And this is again the comparison showing what are the grade 3 related side effects if we do the combination of drug, and if the minimal is seen in combination of avelumab plus exitinib. So why in the previous diagram we have seen that there is less of the corticosteroid use in avelumab plus exitinib because of lesser chances of pneumonitis, and why the lesser use of corticosteroid is important because it increases the compounding morbidity, it leads to potential resistance, altered tumor dynamics, increased toxicity and immunosuppression. So only 15% of the patient has to use corticosteroid in avelumab plus exitinib arm. Also, apart from clear cell carcinoma, we can see the avelumab plus axitinib had role in sarcomatoid RCC, patient undergoing dialysis, acute kidney injury, and elderly patients. So, avelumab plus axitinib evidence in sarcomatoid carcinoma. It is we can see the benefit of 7 versus 4 months and clear separation of Kaplan-Meier curve. Also, with end-stage renal disease patient, the present data suggests that end-stage renal disease and hemodialysis may not be a contraindication for the use of combination of avelumab plus axitinib, and indeed, patient can safely benefit from such combination therapy. So, avelumab is safer among other IU in advanced RCC with lower risk of the kidney injury. So, first line avelumab plus axitinib, favorable efficacy across age group. We can see whether it's overall population less than 65, 65 to 75 or more than 75, and across all the age group, the combination of avelumab plus axitinib is safer and also has maintained its efficacy. So nivolumab had the greatest pneumonitis events and avelumab having the least. Avelumab produced the least exacerbation and the risk for pleural events was highest with nivolumab and lowest with avelumab. Pembrolizumab had the greatest sarcoid events followed by nivolumab with avelumab producing the least events. This is just the comparison of the various side effects. So for advanced RCC patient, we need to strike a balance between the efficacy and safety. So summary, advanced RCC is selecting the right therapy for right patient. Favorable risk group, avelumab plus axitinib had the better hazard ratio. IMDCC poor risk group, avelumab plus axitinib 42% reduction in risk of death. And safety, low discontinuation, lesser steroid use, and better pulmonary safety. Subgroup, we can see in acute kidney injury patients and elderly patient in sarcomatoid component. Avelumab plus axitinib maintains its effect. So avelumab plus axitinib strike a balance of safety and efficacy. Thank you so much for your kind attention. Thank you.
Thank you, Pulkit.
Thank you, sir.
I think we should move. Is there any
Yes, sir.
question? So we can wait for few seconds if someone is there to ask question. Okay. So I think we should move to next session now. Thank you,
Yes,
Pulkit.
sir.
You can
Thank you, sir. Thank you.
you can stop sharing your slides now.
I
So
have stopped
next
it, sir. I have
session,
stopped.
yeah. Next session is by Dr. Arpit Jain, who is a consultant medical oncology at Rajiv Gandhi Cancer Institute, New Delhi. And he will be speaking on enfortumab vedotin in refractory bladder cancers. Over to you, Dr. Arpit.
Yeah. Good evening. Thank you, sir. Thank you for the organizers. And thank you, Estella, also for having me here.
Welcome,
thank
Dr. Arpit. Welcome to the conference.
Yeah, thank you, sir. So kindly confirm that my slides are visible and the audio is okay.
Yes, sir, visible.
Yeah, thank you. So I will be discussing the role of the PET-CIV, that is enfortumab vedotin, in the advanced or metastatic urothelial cancer or urinary bladder cancers. So at the outset, this session is, I would like to clear that this session is sponsored by Estella's Pharma India Private Limited. And these are my disclaimers. So to begin with, the treatment options related to the locally advanced or metastatic urothelial cancers remains to be very few. Till the inception of the chemotherapy era, till 2023, I hope, with the advent of the enfortumab vedotin in this setting. So we know that up to 50% of the patients of the metastatic urothelial cancers are remains to be cisplatin ineligible, and around 50% of the patients are response to the chemotherapy, and only 70% of the patients do not respond to the ICIs, whether it is Pembro, Nivo, or any other. And the 5-year survival is again limited to 5% only. So definitely in this particular subset, there is a limited options, therapeutic options with very limited efficacy also. Then comes the EV, which I will be discussing in the metastatic or locally advanced setting after progression of the 2 lines of therapy, including platinum-based and the prior ICIs. So I would like to start with EV301 trial. So this is the trial schema. Patients who have progressed on 2 prior lines of therapy, including platinum and the ICIs. So EV301 was designed to confirm a clinical benefit of the EV compared with the chemotherapy. That could be any of the taxanes, that is docetaxel or paclitaxel, and or the vinflunin also. So patients, they have a poor survival. Most of the patients are unfit in this particular setting, that is third line setting, and most of the chemotherapies have a very dismal response rate to the tune of only 10 to 15%. Similarly, PD-1 PD-L1 blocker have also a very low response rate to the tune of 15 to 23%. In this particular setting, EV301 was designed. This was the schema. Around 608 patients were enrolled, and they were randomized into 1:1 with EV. And the dosing schedules was 1.25 milligram per kg, day 1, 8, 15 every 28 days, in comparison to the investigator chosen chemotherapy that includes docetaxel, paclitaxel, or vinflunin. The primary endpoint of the trial was OS, and the secondary endpoints were PFS, ORR, DCR, CRR, and so on. And very importantly, the safety outcome measures also. So this was the demographic profile of the patients, which were very well balanced across both the arms. So the median age of the patients were around 68 years. And they also enrolled the patients with the age of more than equals to 75 years. So around 17% of the patients were there in the EV arm, which were having a more than 75 years of the age. Then if we see the patients with the all the patients with a good PS were only enrolled. The patients with upper urothelial UTUCs were also included. Around 32% of the patients were with the UTUCs. The patients with the variant histologies was also included. So around 15% of the patients having a mixed histology, and around 9% of the patients were having a other histology, including the sarcomatoid or neuroendocrine were also included. 77% of the patients in the EV arms were having a visceral disease upfront. Around 13% of the patients were having more than 3 lines of the therapy in this. So if we see the primary endpoint, that is OS, and they found that the median OS was 12.88, which was significantly in favor of EV, versus 8.97 only, with a significant HR value of 0.70. That means EV significantly reduced the risk of the death by 30% in comparison to the chemotherapy arm. If we see the benefit, OS benefit across all the various subgroups is again favoring the EV, be it be the visceral diseases, be it be the number of the lines of the therapy previously received. So all these subgroups are favoring the use of the EV in terms of improvement in the OS. Similarly, the secondary endpoint was PFS, again favors the EV with a significant reduction in the risk of the progression or the death by 38% to the tune of 5.55, which is favoring the EV in comparison to the chemotherapy, which was only 3.71. And again, if we see across all these subgroups, including the primary site, whether it is involving the bladder only or the UTUCs, whether the patient's having a PS of 0 or 1, whether the patient was responding to the prior ICIs or not, every other subgroups is favoring the use of the EV over the chemotherapy in the third line setting. That means post progression on the platinum or the ICIs. If we see the response rate, again with the use of the chemotherapy, it was only 18.6% as per the historical data, with a partial response of 15% only with the use of the chemotherapy, while it was around 2 times higher with the use of the EV to the tune of 41%, with a complete response of around 7%, which is significant. in the third line setting in the urothelial bladder cancer, which was supposed to be a barren land in terms of any kind of the therapy options. So with the use of the EB, the confirmed ORR was 2.2 times higher in comparison to the chemotherapy group. If we see the responses uh, in terms of the various subgroups of the patients, it again favors the EV. So again, if be it be the liver metastatic status or not, be it be any line of the therapy, including more than 3 lines of the therapy, it favors the improvement in the ORR with the use of the EV in comparison to the chemotherapy. The very important discussions regarding the use of the EB in the third line setting is come with the added toxicities or not. So if we see this very important outcome measure, that is quality of life. So they assessed the quality of life with the EORTC QLQ C30 score. It again favors, at least there is no additional detriment in the quality of life score with the use of the EV in comparison to the chemotherapy, although the use of the EV improves the with the excellent responses, it improves the pain of the patients, related quality of life of the patient. So EV was associated with the numerically smaller deteriorations and less variability in the patient reported quality of life scores compared with the chemotherapy. So all the domains of the quality of life measure score, be it be the functioning domains or the symptoms domain, that includes the pain, fatigue, dyspnea, or constipations, was favors the use of the EV in comparison to the chemotherapy in this particular trial, that is EV301. And there is a significant reduction in the pain also compared to the baseline with the use of the EV. Similarly, if we see the treatment related adverse events, they were almost equal as was there with the use of the chemotherapy. Although the class of the side effects were different. With the use of the chemotherapy, the hematological treatment related adverse events were more common, while with the use of the EV, the side effects which were supposed to be the class effects, which includes the skin toxicities, cutaneous reactions, including pruritus or maculopapular rashes, the neuropathy, including the sensory or the motor, and the fatigue, are more common with the use of the EB, and they are the side effects which are having at least the incidences were at least more than equals to 10% in comparison to the chemotherapy. So with the use of the EV, the peripheral sensory neuropathy of any grade was there in 1/3 of the patients. Similarly, pruritus was again, so peripheral neuropathy, pruritus, and fatigue was there with the use of the EV in around 1/3 of the patients. Maculopapular rashes was again seen in 16% of the patients. Neutropenia of any grade was seen in 7% of the patients, while it was seen in 4.7% to the grade of more than equals to 3. So, so EV is again associated with the some kind of the class side effects, although the grade 3 or more side effects were very less, or even with subsequent learning with the management of the side effects related to the EV becomes more and more wiser, and and most of the toxicities are manageable. Similarly, if we see the treatment emergent adverse events leading to the deaths was again comparable with the chemotherapy. So around 7% of the patients were having TEAE leading to the death in EV arm. Similarly, if we see the treatment related adverse events leading to the death in the EV arms were there in only 7 patients out of 296 patients, that is 2.4% of the patients, and that too were related to some kind of the neutropenia related further worsening of the underlying infections or something. So the pneumonia was there in one patient. Septic shock and neutropenic sepsis was again in one and one patients. So most of the patients were underwent the event because of the related to the neutropenia and subsequent side effects. Similarly, hypercalcemia related event was there in one patient, and multi-organ dysfunction syndrome was there in two patients, leading to grade 5 toxicity or death. Similarly, if we see the modifications of the EV dose because of some kind of the treatment related adverse events were there in around 1/3 of the patients, and that too were related to the peripheral neuropathy in 7 patients, rash in 4 patients, and so on. Similarly, the dose interruptions was there in around one half of the patients. So 50% of the patients, they underwent dose interruptions because of the treatment related adverse events during the course of the EV, mostly in the later time after receiving at least 6 or 8 months of the therapy. So the prime cause was peripheral sensory neuropathy in 15% of the patients, neutropenia in 5% patients. Similarly, macular papular rashes in around 5% of the patients. And if we see a detailed profile of any kind of the adverse events of the special interest was again numerically comparable with the control group, that is chemotherapy. So if we see the any grade of the skin reactions was there in 47% of the patients, and in grade 3 or 4 was there in around 14% of the patients. Similarly, peripheral neuropathy was there in one half of the patients. Ocular disorder is again very common with the use of the EV, and we again counsel the patient regarding the use of some CMCs or lubricating eye drops on a prophylactic basis. So dry eyes was there in 15 patients. And similarly, infusion related reactions are again common in around 8% of the patients with the use of the EV. And hypercalcemia is again, glycemia is again very common in around 6% of any grade with the use of the EV. And importantly, the chronological profile of the onset of the any kind of the side effects is again showing in this chart. So usually peripheral neuropathy is a cumulative side effects usually develops in the 3rd month of the patient of the starting of the treatment. Similarly, corneal disorder is again a late side effect. Infusion reaction or hyperglycemia and the skin reactions usually develops in the 1st month of the starting of the EV, initiation of the EV. So if I summarizes the outcome of the EV301 trial, so the primary endpoint was meet with the use of the EV over the chemotherapy to the tune of 12.9 months versus 8.9 months with a improvement of around 30%. Similarly, median PFS was again reached. ORR was favoring around 2.2 times the EV, and there is a significant reduction in the pain and improvement in the quality of life score. So this was
Sorry to interrupt you, sir. Sir, please conclude in next 2 minutes.
Yeah, sure. So this was the clinical trial setting. So how does the EV do in the real world setting? So this was an important UNITE study registry of around 16 US institutions. 260 patients were enrolled. The ORR was again 52%. In clinical trial, it was 45%. It again favors the use of the EV monotherapy per se in the 3rd line setting across all the histologies, be it with a pure urothelial or any other variant histology also. It again favors the lower GFR patients also. It favors the EV in the irrespective of the FGFR3 status also. Then comes the so this was in the North American setting. Then comes the study with the in the German or the Swiss hospitals registry. So around 188 patients were enrolled. Again, ORR was 46. PFS and OS was more or less similar to the 301 study. Again, shows a significant improvement with the use of the EV monotherapy in the third line setting. So this study was from the Japan. Around 97% patients were enrolled across 5 centers in the Japan. Similarly, clinical response rate was similar, 43%, and the toxicities was again very well in line with the incidences what we have found in the 301 study. PFS OS again both favors the use of, and the important findings that this trial has shown that all the patients who have developed any grade of the peripheral neuropathy also shows that the improvement in the PFS and OS was also there. So although it's a hypothesis generating idea that all like in this situation
I think he is disconnected.
Yeah. Anyone from the organizing team can just have a connect with him, or we can move forward.
I think there may be network glitch.
Yes, yes, ma'am.
Sir, I am calling him.
Sir,
We need Gupta to.
I think we should move on to
Yes, sir.
next
Yes,
section
sir.
now.
Yes, sir.
Already
Yes,
we
sir.
are late by 1 minute.
Yes, sir. Yes, sir. Please, sir.
Okay. So next session is by Dr. Asim. He is the Director of Medical Oncology at CK Birla Hospital, and he will be speaking on the RUBY trial, which is survival impact of Jemperli in first-line endometrial cancer. Welcome, Asim.
Thank you, sir.
How are you?
Fine.
Good.
Good and adjusted to the new environment.
Feeling good at new place?
Yes.
Great.
Corporate hospitals feels good initially, I guess.
Yeah.
Good evening, sir, and welcome, and thank you so much, sir, for taking out time for the conference, sir. Thank you so much, sir. It means a lot.
Thanks to you also for involving me as a part of your conference. So thank
Yes, sir.
you, and we'll start.
Yes, sir.
Okay, so this is all the slides were given by the GSK, and it is a sponsored session where all the datas are submitted to me as a presentation by the GSK. So GSK is a sponsor of this session and has a role in the selection of the speaker, topic, and the content. Next, please. So immune checkpoint inhibitors and chemotherapy rationale in the endometrial cancer. We all know up till this date in the advanced or recurrent endometrial cancer where metastatic disease are there, we used to use the chemotherapies as a backbone of the treatment part. So we started with the paclicarbo, and for many years we used this backbone. And now we want to involve the immune checkpoint inhibitor, and for that purpose, Ruby trial has done the good for us. And Jemperli is the molecule name, trade name for the dostarlimab. And dostarlimab gained good media hike and buzz when it was used in the colon or colorectal cancer. So now we are discussing this endometrial cancer. Next, please. So this is the normal mechanism of the immunotherapy, immune checkpoint inhibitor. It trains the T cell of the host, and it blocks the signals. And what you call is it can activate your native immune system to kill the tumor cells by the PD-L1 receptor. Biomarker testing. Next, please. Yeah. So till this date in the US data, if you look at the SEER database, they say like almost 83% of their endometrial cancer patient goes for the molecular testing, and they're being tested for the HRD, DDMMR, and MSI high testing. So in India, it is the ratio of getting tested is very low, and the percentage positivity for this DDMMR or MSI high is around 25 to 26% in all stages across the board. So the message is we need to test almost each and every patient if they can afford, or at least we should assist them to get this test done, because we have a wonderful drug against the particular genomic abnormalities. So if the patient are DDMMR or they can afford the drug, the results are fantastic. DMMR endometrial cancer tumors can be associated with a higher rate of recurrence versus the MSI high tumors, and a mutation that increase the risk of Lynch syndrome, which is an inherited condition that increase the risk of endometrial cancer. We all know Lynch syndrome has a good relation with the endometrial cancer in some sarcomas, and it runs through the family and a strong correlation with the germline testing. And if they are positive, then we should look at this. And motility test for the DMMR and MSI high. So ISC, we can to use ISC, we test the DMMR, and by the PCR and NGS, we say like this is MSI high or MSI low or MSI stable. Next, please. So it is recommended in all patients to do the test by any method, but usually prefer with the both ISI, ISC and the PCR method. Ruby Part 1 trial results. Next, please. So GSK people told me like they have given their molecule and trial name on the basis of the semi-precious stone name, ruby and pearl and all that. So it is their choice, and they have used in all comers with the primary advanced recurrent endometrial cancer. So they have tested, the odd number was 494, and they have done the DMMR testing and MSI high testing. So they have randomized this population in 1:1 fashion. In one group, which is an experimental group, they have given Jemperli plus chemotherapy. Chemotherapy backbone is same paclitaxel, and additionally they have added the Jemperli in the experimental group. So this dostarlimab was given 500 mg 2-3 weekly for 6 weeks, along with the paclitaxel in the standard dosing schedule and carboplatin also. After that, they have given 6 weekly in the experimental arm for 3 years. This is quite a long years they have given. But in the placebo arm, they have used for the 6th cycle, and then the patient were observed with the placebo for 3 years. Patients were discontinued if they had major toxicity, and the primary endpoint was OS, PFS, and OS and PFS in all comers, and PFS in the DMMR. Next, please. Yeah. So primary patient subset was stage 3 and stage 4 endometrioid cancer or endometrial cancer, and including patient with the more aggressive histologies such as the carcinosarcoma and serous adenocarcinoma. Earlier we used to see in the various trials when these kind of the population were ruled out because they were aggressive and they can skew the results. But in the this Ruby trial, they have involved all comers, and so all 4 varieties of the endometrial cancer they have involved. So they needed only the measurable disease in the stage 3 and 3C1, and measurable and non-measurable disease also in stage 4 they have included the patient. So the patient population was across the board was very homogeneous. They have used Caucasian patient and Black, Hispanic also, and Asian patients also. So it is a widely applicable trial. First recurrent endometrial cancer with a low potential for cure by radiation therapy or surgery alone or in combination, including those. Okay, next please. Yeah. So diverse disease characteristics, we know the endometrial cancer can be divided into 4 major varieties. The highest rate, what you call is highest probability of having this histological variant is endometrioid carcinoma, which is almost 55%. 10% patients are having carcinosarcoma, 20% serous adenocarcinoma. Sometimes they are very difficult to isolate it from the ovarian cancer. And other histological varieties are clear cell carcinoma, mucinous, undifferentiated, and mixed carcinomas. So these are these. And next, please. Yeah. So as a whole, if you see the results, the major endpoint was achieved. The 16.4-month improvement in the median overall survival versus chemotherapy carbopecli alone. So in the experimental arm, there was a very good improvement in the overall survival, and the hazard ratio for overall survival was they have mentioned like in the Kaplan-Meier curve, overall survival at the 24-month in the experimental arm was 70% versus the 54.3% in the CP arm. So almost 25% difference was there, and the median overall survival benefit at the end of okay. So there is 31% reduction in the risk of death with the Jemperli plus chemotherapy versus chemotherapy. So the HR ratio was 69%, 0.69. Next, please. Yeah, and you see the PFS curves, those with the aggressive histologies. So statistically significant 36% reduction in the risk of progression or death with the Jemperli plus chemotherapy. And at the cutoff of 12 months, the median PFS reached was at 11.8 in the Jemperli group versus the median PFS of the chemotherapy carbopecli was 7.9 months. So it was the p-value for this PFS was 0.0001. So it's highly significant. Hazard ratio was 0.64. Next, please. So you can see 36% patient had reduction in the PFS. More patient achieved overall response with the Jemperli. You can see the overall response rate in the experimental arm was 70.3%, which included 45% partial response and 25% CR. Remember, these patients were recurrent and advanced stage cancer. If you go for chemotherapy alone, so overall response rate was 64.8%, 45% were partial response and 19.6% CR. Next, please. The median PFS was not estimable with the Jemperli and 7.7 months with the CP alone. So in the experimental arm, it has not been reached up to the median. So until the 36 month of the follow-up. So it may be the PFS is very high in the experimental arm. Next, please. Yeah, and overall survival also is high, quite high. In the placebo arm or the peclicarb arm, it was 31.4 months, whereas it has not been reached to the median in the experimental arm. So at the 24 month, you can see the 82% patients were surviving in the experimental arm, while in the chemotherapy alone arm, it was 57.5%. So almost 25% increment in the overall survival. Next, please. This is again the same thing. Next. And the 7-month difference in the median was observed in the Jemperli plus CP and CP alone. This is the same repetition. Next, please. Okay, this is the doses regimen of the dostarlimab in combination with the peclicarbo. So cycle 6, they have given with the 500 mg dose, and after that, every 6 weeks they have given the 1000 mg dose. And they have done the scans at the 3-month interval. Next, please. Subgroup analysis in the Ruby trial. Next. Okay, so all the pre-specified subgroup they have involved. So it is across the DDMMR and MSI high, polling mutation, NSMP, T53, and oral survival was measured in the same subgroup. So you can see if the patient is DMMR or MSI high, there is a significant benefit as compared to the experimental arm. You can see the graph in the first one, in the right side first one. The graph are so widely separated that the bottom curve is you cannot find it, and it is not reached to the midline or median PFS. Hazard ratio for PFS was 0.31, and overall survival, the hazard ratio was 0.40 in the dMMR population. So you can say if the patient is dMMR or MSI high, then it is clearly the Jemperli has made the good impact or very good impact in such population. And POLE mutation, you can see the graph are overlapping, so there is no benefit. NSMP margin benefit is there. TP53, again their benefit is significant. So the two subgroup, you can see dMMR and the TP53 PFS benefit is significant, and overall survival benefit is also significant. Next, please. Yeah, so subsequent immunotherapy use, the always we ask the question when we read the trial which has coming up very recently. So we always ask our colleagues that what will be happen in the next if the patient has progressed. So in this subgroup, you can see the discontinued dostarlimab or placebo because of progressive disease was 14. 14 patient discontinued, and in the placebo arm it was 40. So almost out of 28, 15%, 28% patient got the next anti-cancer drug. So 8 out of 15 got immunotherapy. Out of them, 4 had pembrolizumab and 3 had pembro plus lenva. Dostarlimab has nothing. So after progression on the one immunotherapy, few patients got the other kind of the immunotherapy. That is the message. Next, please. Yes. So PFS2 results were also better in the dMMR or MSI high. PFS2 result, overall survival, and these were the better in the patient who got the dostarlimab upfront. Next, please. Adverse drug reactions. So as we all know, it is a immune checkpoint inhibitors. Next, please. Immune checkpoint inhibitor. So it has a whole variety of the immune-related side effect. You can see the nausea, alopecia, and fatigue were higher as compared to the chemotherapy alone arm. Or you can see the very marginal difference was there. These are the all chemotherapy related side effects. So these are as common as with the experimental and the placebo arm. So the most common AEs leading to discontinuation of dostarlimab were the infusion related reaction in 1.2% of the patient, severe maculopapular rashes in 1.2%, and patient in the dostarlimab group was thrombocytopenia 1.2, and 0.8% had in the placebo group. So not much you can see the great adverse event happened in the experimental arm. Next, please. 19% patient had discontinuation. So these are the list of immune related side effect in the experimental arm. So patient might have neurological toxicities, various endocrinopathies, pneumonitis, cardiovascular toxicity, hepatotoxicity, renal, colitis, cutaneous toxicities, and musculoskeletal. So sometimes the immune related side effects were severe. And next, please. So they have given the list where you can permanently stop this drug. So dose reduction of the Jemperli is not recommended. Dosing delay or discontinuation may be required based on the individual safety and tolerability. Recommended modification to manage adverse reaction or summarizable in the next slide. Next, please. Next. So yeah. So you can see if patient has a grade 3 hepatitis or grade 3 colitis or grade 3 or 4 pneumonitis and the adrenal insufficiency, you need to permanently stop this drug. Only grade 1 or grade 2, grade 1 or grade 2 pneumonitis, you can withhold the drug and again you can restart if the symptoms will disappear. Same is true with the colitis. Same is true with the hepatitis. But anything which causes inflammation in the visceral organs and it is grade 3 to grade 4, then you need to permanently discontinue this drug. Next, please.
Sorry to interrupt you, sir. Sir, please conclude in next 2
It is
minutes.
last 1 or 2 slides or more. Next, please. Next. Yeah, so it is a safety information. Next, please. This we have already said. Summary. Yeah. So this is the important slide. Dostarlimab plus chemotherapy. This is an IO combination with a statistically significant OS benefit in all comers versus chemotherapy alone. So whether the patient are MMR proficient or deficient, both have gained the benefit, but the benefit was certainly more in the dMMR population. 16-month improvement in median OS for all comers versus chemotherapy alone. Significant OS benefit with hazard ratio was 0.69, and the pre-specified exploratory analysis in patient with dMMR or MSI high endometrial cancer, median OS was not reached with the dostarlimab plus chemotherapy versus chemotherapy 31.4 months. So these were the data in 2022. Now we must be having the updated results. Pre-specified exploratory analysis in patient with proficient MMR, it was 7-month improvement in the median OS was seen in the chemotherapy plus Jemperli. And this was a robust trial design. They have given the 3 years follow-up, and the safety profile is manageable. 19% patient discontinued because of the immune-related side effect. Next, please. I guess, and we know the pregnancy and lactation, this drug is contraindicated, and children, and but there is no safety issue with the children and geriatric population. Next, please. Next. So I guess this was the last slide, and I will end it here. And any question, I would be happy to answer that. So Pulkit, over
Thank
to
you,
you.
sir. Thank you, sir. Sir, I just want to ask, like, did you
Yes.
had any personal experience of dostarlimab in
Yes,
endometrium
yes.
or in colon?
Yeah, we
Okay.
had given to 3 patients, and they all are doing well till this date.
Okay.
So there were no side effect related to the
So,
immune-related
Asim,
side
what's
effect.
your take on this PMMR or NSMP population of endometrial cancer? It's very good
NSMP,
for DMMR.
yeah.
So,
The subset analysis had shown actually no benefit with the NSMP subgroup. So if you find it out like patient is NSMP, then you may not waste the money of the patient. But DDMMR and the MMR proficient both had gained the benefit. That is the
yeah.
important thing.
Uh, Hi, sir. Sir, I also want to ask, sir, there are two trials for immunotherapy and chemotherapy, that pembrolizumab. So how would you like prefer, and in whom patients you would prefer dostarlimab versus pembrolizumab?
It's a tricky question, but when we will sitting in this Pulkit's conference, and we will prefer dostarlimab. Now, jokes apart, dostarlimab has given the good result in all comers. Remember, but in the this Pembro Lenva trial, the population was very limited. Though they have given the benefit in the proficient subgroup also.
Proficient
But
also they showed.
yes, it was there and it is approved also. But the margin of benefit was less as compared to the this Ruby trial. But it is a cross trial comparison. Both the drugs are approved, and we can use both. So there is no preference over other scientifically, but the duration and follow up is more with the this one Ruby
So
trial.
where do you put like TP53 mutant patients? Like they will be, they are
So they have
population.
this Pembro and Lenva trial. They have not mentioned anything about the
Yes, about this
TP53.
molecular
But
subgroup.
in this Ruby trial, they have given the subset analysis, and by convention we know like TP53 mutations behave very badly. But
Yes.
with this drug, they have behaving in the favor of the improvement in the overall survival in the PFS. So if you find it out like they are TP53, then there is no choice. You should give the dostarlimab based combination.
So it was a great session, really. And I also have a question for Dr. Pulkit.
Sure,
So
ma'am.
what is your first choice for RCC? Of course, based on risk groups, and why?
So
So
I think, ma'am, the data which was presented in favorable risk group, I think we have seen that avelumab plus exitinib do had a choice. So one thing is clear, exitinib is the most easily tolerable TKI because of the shorter half-life clearance. Now, if we have to choose between pembro exi and Bavencio exi, if it's a favorable risk group, the data of 70 months follow-up suggests that Bavencio plus like avelumab plus exitinib has the strongest upper hand. But if we go with the intermediate risk or unfavorable risk, we can choose either Pembro or Avelumab, depending on because there is no. The only difference is that in Avelumab, the chance of ILD was pretty less. Although I have not experienced too much of ILD even in Pembro. But if we talk about the highest efficacy, that is shown with Pembro plus Lenva. But unfortunately, Indian patients cannot tolerate the full dose of Lenva, tenib of 18 mg as per the trial. So for favorable risk, hands off, I give to Evolumab plus Exitinib. And for intermediate risk and unfavorable risk, it can be either Pembro-Exi or the use of Evolumab plus Exi. But if the patient is having hypersensitivity or previous hypertension, then comes the role of dual agent of IO-IO. So this is my sequence and points to choose IO plus TK. Asim sir, you want to comment something on that, sir?
So
Anything
you
your
don't
take?
want to include Nivo EP?
That's what I said, sir. I want to include Nivo AP, but only in those patients who cannot tolerate TKI. Given a choice, sir, my first choice for a de novo metastatic advanced RCC patient, I would definitely want to use the betterment of both TKI as well as IO because of the synergistic mechanism of action. And
Although
even the
IO is also difficult combination to tolerate. It is not very
yeah,
easy.
yeah,
Because
even sir,
so
I
much
think the
toxicity.
effect is little slower if we think of as compared to IO plus TKI, sir. Anything you want to comment on that, sir?
No, actually, in very early phases of our using of this immunotherapies, we noticed like if patient has a weight disease, like patient has a pleural effusion or some ascites or some this kind of component, then they need TKI to resolve it because
Yes,
the IO is lately affect the body, and they take at least 8 weeks to came into the action.
yes,
But
sir.
the
Yes, sir.
patient who got the this kind of the dry disease, or you can say the only the visceral mats or bone mats or lung mats, then they are very good drug, very good combination. And we
Okay,
had the
okay, sir.
cosmic study results also, though the trial was negative. But
Yes, sir. Trial
if
was
you
negative.
use the Nevo EP plus cabozantinib is lesser dose like 20 mg, then the the problem of effusion is also gone. So this is
Great,
the
sir.
thing. And
Yeah, yeah, sir.
cabozantinib is multi-kinase inhibitor. So it
Yes,
is
Yeah,
a
sir.
drug.
exactly.
Yeah,
You can
yeah.
you can use with the Nivo plus Cabo, Nivo EP Cabo or Nivo EP. So Nivo
And
EP is a
yes, sir.
good combination. And axitinib, why we prefer is short acting half life. And
And lesser side effects, sir.
Lesser,
after
Yeah.
quite
axitinib,
easily tolerated.
yeah, and after axitinib, you have a choice of using cabozantinib.
And sir,
Yes,
there
sir.
are the young patients also. Sim sir, good evening.
Good evening.
Sir, there are the young patients and many patients with RCC with there are the low disease burden. So this IO combination, there are the OS and PFS are more than the TKIs. So
Yes, yes.
it
There,
is better, and our experience with Pembro and Exitinib is better in comparison of Avelumab. So I feel if the burden is more, then there are the options of Exitinib or TKI or Cabozantinib is there. Nivolumab is also there, but it is inferior. And if the disease burden is low, patient is young, and we go for the longer periods, then IO is better in my choice.
The thing is, Sudhir,
Same.
actually
I
in the
think,
IO,
Asim,
yes, sir.
I think we should stop this discussion here and
Discussion.
because we are
Okay,
getting
sir.
late for the next
Yes,
session.
yes.
So
Okay.
thank you all the speakers and we will conclude this session right now here.
Yes, sir.
Over
And
to
thank
the
you. Yeah,
organizing team.
yeah. Thank you, Asim sir. And thank you, chairpersons, Dr. Deepak Gupta sir and Dr. Aditi Mittal ma'am, for chairing the wonderful GU session. And now we are moving towards the GI session. And I would like to welcome the chairperson, Dr. Ram Daga sir, who is a very senior gastro surgeon in prestigious SMS Hospital and Medical College. Sir, can you hear me? Welcome and good evening, sir.
Hello,
Dr.
Asim. Good evening. I am able to hear you. Am I
Sir, Dr. Pulkit,
audible?
Dr. Pulkit this side, sir. Good evening, sir.
Dr. Pukul, I am audible. Am I audible?
Yes, yes, yes.
Yeah.
Dr. Asim is also back, sir. Thank you. You called him back.
Actually, I had to leave this meeting because there is some family function. But good evening, Ram Daga sir.
Good evening, everyone.
Good
I think
evening.
we can start our next session on the
Yes,
GI
yes,
cancers.
sir. Yes, sir. Yes, sir.
Yeah.
Please, sir. Dice
And
is all yours.
speaker is Dr. Sudhir Palsania, and Dr. Sudhir is consultant at Shelby Hospital, Jaipur, and he
Good
will
evening,
be
sir.
giving his talk on new era in managing resectable gastric cancer with D plus float.
Good evening, Dr. Sudhir, sir. And thank you for joining and taking out time. Thank you, sir.
Good evening, Pulkit. Thank you so much for the opportunity.
Thank you, sir. Thank you, sir. The dice is yours, sir. Please go ahead.
Okay.
So, are you sharing your slides or organizing teams to share it?
Oh, I will share it.
Okay, okay, okay.
So now it is visible.
Yes, sir, visible.
So there is a one more
Sir, make it
specific.
full screen कर लीजिए please.
जी जी. Okay, ma'am.
Yes, sir, perfect. Perfect.
Yeah. So now we discuss a new era in the managing of resectable gastric cancer. There are the many eras with the resectable gastric cancer. We use many chemotherapies, but then come the float. And now after the float, there are the chances of recurrence are there. So we addition of durvalumab is there. So we talk about the first the overall gastric cancer burdens, then the current management, and then why we need the perioperative IO. And there are the major trial is methadone data is there, and there is summary. So this is the gastric cancer. It is the leading cause for the cancer-related deaths. In the stomach cancer is the second most common GI cancer among males and third most common site in the females. So this is the demographic data only. So management of the resectable gastric cancers, they are the stage 1 and 1B. They are the endoscopic or surgical resection. Stage 2 and 3, they are the resectable gastric cancers. So they are the standard is the perioperative chemotherapy with the surgery. And stage 4B is the only systemic. So perioperative chemotherapy for resectable locoregional gastric cancers, clinically T2 or more, and any node. So this is the category 1, and we all practice that. But the many patients with gastric cancer experience disease recurrence after the surgery, and this new adjuvant chemotherapy also. So what is the proportion is around 39%. And within 2 years, there are the of the surgery, there are the 57% are the recurrence chances are there. So with surgery alone, there is high unmet need. 61% experience recurrence post surgery, and 43% patients are recurrence after 2 years of the surgery. So Magic established a perioperative chemotherapy first time, that is the ECF, and we practice that perioperative chemotherapy compared to surgery alone. And there is a 5-year overall survival 36% versus 23% in the first trial. Now it is the standard of care now, float 4 study. So it compared with both of the ECF and ECX with the surgery. So there are the histological confirmed adenocarcinoma of the stomach or G junction type 1 to 3 all are, and sufficient bone marrow is there, total bilirubin, they are the normal criteria for that. And we thought there the endpoints are median OS, that is the 50 months versus 35 months in the ECF ECX group. So this is the better chemotherapy arm for the perioperative. And median DFS is 30 months with the float regimen and 18 months with the ECF or ECX arm. So perioperative float is now standard of choice of the with the surgery. So this is the again, if the patient is not tolerating the float, then there is the modified float. In modified float, we give the 5FN divided dosage day 1 and day 2, 2400 mg per meter square, opposed to the 2600 mg in day 1. That is the original float data. So modified float is also feasible with high completion and manageable toxicity, and early survival outcome were similar to result of float study. Now this is the perioperative patients. So AOX or AM float are there. So there the P value is significant, and outcome is curative resection around 86% of patients. So AM float is better survival with the tolerability in comparison of AOX. So both float and modified float are better perioperative regimens. So now proportion of the patient alive after the 5-year perioperative selectivity. So there are the around after the perioperative, there are the 45% and 55% are the alive. And the PCR is around 84%. So 5-year OS with the adjuvant as1 chemotherapy by the gastric junctions are the 84 in the stage 2, stage 3 by the 50%. So despite the positive impact of the associated therapy, recurrence rate remains high in patients with resectable gastric cancer, so gastric junction cancer. So most patients experience disease progression within 5 years following treatment with perioperative float with an estimated 5-year overall survival of 45%. So there is a significant unmet need to identify the novel neoadjuvant or adjuvant regimens better than float or resectable or G junction. So there are the need of the perioperative immunotherapy because the immunotherapy primes the systemic immunity by exposing tumor antigens, clear minimal residual disease, Y-activated T cells, and build immune memory for long-term cancer surveillance. So this PDL1 is found around 40 to 60% of G-junction gastric adenocarcinomas and supporting anti-PDL1 therapies. So there are the major trials, 4 type of trials with the pembrolizumab also. There are perioperative durvalumab also, perioperative atezolizumab and perioperative nivolumab with the perioperative city with adjuvant nivolumab. So who are the negative trials, pembro and nivolumab? But there are 2 trials, they are positive, but atezolizumab is still awaiting the PFS data. So one positive trial is there, that PCR benefit also there, EFS benefit also there, and OS benefit is also there. It is still pending, but now it is there is OS benefit also. So the perioperative durvalumab plus float, previously untreated gastric cancer stage 2, stage 3, any node positive or more than T2. So this is the trial we talk about. So they are the negative trials, keynote and attraction, and this is the positive trial. Only positive trial. So the FDA approves also the durvalumab for resectable gastric or gastroesophageal junction adenocarcinoma. On November 25, 2025, the FDA approved this Imfinzi with float. So this is the newer thing, and the new adjuvant and adjuvant treatment both, and with the single agent followed by the single agent durvalumab in adjuvant casing. So this is CDCO also approved the durvalumab in gastric cancers in the India also. So now we talk about this trial. See, this is the methadone trial. Phase 3 trial is there. Randomized double-blind placebo-controlled trial, multi-center global trial for the addition of durvalumab neoadjuvant and adjuvant durvalumab in combination with float, standard of care. So histologically documented resectable stage 2, 3 or 4A cancers, T2 or more or node positive, and PDL1 expression both TAP score is used less than 1% or more than 1%. So we use the durvalumab 4 weekly with float in the neoadjuvant versus placebo. Experimental arm and adjuvant 1 year duration is there. So as we know, float 4 cycles or 2 cycles day 1, day 15, and followed by the durvalumab 4 weekly for 10 cycles. This is the scheme of the trial. So primary endpoint is PFS, secondary OS, PS, pathological CR, and safety and tolerability. So this is the durvalumab plus float and placebo plus float. There are the completed cycles are around same 96 or 95, and surgery are 87% patient undergone for the surgery and 84 in the placebo arm, and completed treatment around 77 or 74, but around 1 year treatment only for the 52% because the drop out after the some time. So these are the baseline demography. They are the all matched. So first thing is EFS. Primary endpoint is EFS. So 18-month EFS rate durvalumab plus float is 73% versus float alone is 63%, and 24 event-free survival is 67% versus 58%. So both curves are definitely separating, and there are the float alone median EFS as 32.8 month only with the 73% patients at the 18 month. So EFS in many subcategories, age, geographical, PDL1 expression, primary tumor locations, all are favors the durvalumab. This is the HR ratio. It is around 0.71 to 0.56, around 46%, 42%, 39% more favorable to the durvalumab with the float. And this is the we are awaiting the median OS, and median OS is not reached. Now the durvalumab plus float is there, and with the 39.8% at the end of the 36 months. So there are the follow-up of 3 year, and they are better with the durvalumab. In 18 months, there are the 4% improvement. There are the 24 month 5% improvement, And in 36 months, there are the 6.7-month improvement. It is still waiting for the more data. So durvalumab is more better with the float. And in key subgroups, we see all subgroups are there. They are more favorable with the durvalumab. But clinical lymph node negative, it is equal. So with the clinical lymph node more positives or PDL1 expression is anything is there. So durvalumab is better with the float. So OS by PDL1 status, there are the median OS PDL1. So in both subgroups, there are the benefit with the durvalumab addition. So pathological, there are one more secondary objective is PCR. So PCR is around 12% odds ratio improvement with the durvalumab plus float. It is 19% versus 7%. So treatment delivery, median number of neoadjuvant cycle with durvalumab is 2, float is 2, and after the adjuvant cycles, durvalumab 12 cycles and float is 2 cycles.
Sir, please
So safety,
conclude in
yeah.
please conclude in 2 minutes.
So this is the key takeaway. 1 minute only. So safety profile is both the groups are equal. See, this is the most common maximum, as Asim sir also discussed. There are the immune related, but they are manageable. Diarrhea is most common AE with the both durvalumab and placebo group because of float also. So this is the key takeaway. The addition of durvalumab to float improved overall and event-free survival in resectable gastric and GE junction cancers. So summaries. It is the fifth most frequently diagnosed cancer and fifth leading cause of cancer-related death worldwide. And float for is established perioperative chemotherapy as the standard, and relapse rate are major challenge now also. So immunotherapy combinations are tried, and in all that Methadone trial, durvalumab plus float significantly improved EFS as well as OS compared to placebo and float in resectable gastric GE junction adenocarcinoma. Benefit was consistent across subgroups. No safety concerns are there. Profile aligned with non-durvalumab and float toxicity, or no significant delay or decrease in number of surgeries is seen in this way. Thank you so much.
Thank you, Dr. Sudhir sir, for the wonderful presentation showing great. Dr. Ram sir, anything you want to ask Dr. Sudhir sir?
Yeah, so they very good insight for this D plus or durvalumab plus float. But I would like to know what are the patients where you will prescribe this therapy. What are the type of patient of gastric cancer? All patient you will start with D float, or there are some selected patient where you will start with float only, or as a neoadjuvant setting. So what are specific indication for D float as of now?
Sir, as we see the benefit is on the all patients with the more than T2 and node positive patients. So we can use the all patients, but the high burden disease or node positive disease or patient is T3, T4, we should use the durvalumab with the float.
Well, I think still it's not in practice. So do you think this is going to be standard of care now onwards or in future? So this is what I think as a surgeon I should take.
Yeah, so float is already there with the standard of care, and now durvalumab plus float is more convincing data. So it is practice changing data. So for the with the if the financial toxicity is not there in the Rajasthan, there is a major factor. Then we use the durvalumab plus float. It is better for the patients.
Can you tell me what is it cost actually? What is the cost addition for float plus durvalumab as compared to float alone?
So for durvalumab, we purchase the 6 cycles, and all the further they are free. So one cycle is cost around 1.5 lakh.
Okay, I
So
think
it is around 10 lakh for 1 year.
as a surgeon, what I believe that these gastric cancer are somewhat most difficult cancer to treat. They are, I think,
Yes, sir.
poor survival as compared to even gallbladder cancer. This is what I will say in
Yes,
resectable
sir.
setting at least. If your gallbladder cancer is resectable or perineal cancer is resectable,
So sir, there is
they
a
do have good
diagnostic.
survival. But gastric cancer, I think, even with so-called large resection, many of these patients come with recurrence, and I think these.
Yes, sir. Because of the systemic activity like the peritoneum, we go for the DLAP also for this stomach cancers. All that things are there. So there is a addition will be benefit for the patients, sir, for the durvalumab.
Sudhir sir, please stop sharing your slides.
Okay.
Ji.
Ram sir, can we move ahead, sir?
Yeah, definitely we can move it.
Okay, sir, please for the next session, sir, please go ahead, sir.
I think next session is from Dr. Deepak Kumar Shukla, and topic is Oncology in one gastric cancer, G junction cancer, and esophageal adenocarcinoma 5-year update. Dr. Deepak Kumar Shukla, please go ahead.
Thank you, Dr. Pulkit. Please, can you share slides from the backside?
Thank you,
Sure,
Deepak
sure.
sir, and welcome, sir. Thank you so much.
Right.
Tech team, please stop.
So again, it is a discussion with the patient. We have approval irrespective of CPS. I personally prefer to use it in patients with CPS more than 5. But again, we know there is approval also of the drug. We can use it. If not now, then we can use in later lines, if at all, irrespective of PD-L1 status. Most of the immunotherapy drugs, I think, if at all they are to be used, they should be used in the first line. That is the
Yeah, that's the
because
best
we
hit.
may not
Yeah.
get a second chance to give the drug. So, but again, it is a discussion if means the benefit predominantly in terms of PFS and OS is driven by PDL1 CPS more than 5. Response rate is improved irrespective of it. So we can decide
Thank you, sir.
on those
Yeah,
factors.
yeah. Thank you so much, sir. Thank you.
Thank you.
Thank you. Dr. Ramdaga, sir, now can we move on to the next speaker,
Yeah,
sir?
I think we can move to our next session.
Yeah, yes, sir.
And speaker is Dr. Deepak Gupta. Deepak is my good friend. He is my batchmate, in fact, from MBBS. And he is presently working at Bhagan Mahavir Cancer Hospital. And he will be speaking on real-world evidence of adjolimab plus bevacizumab in SCC. Deepak, please go ahead.
Good evening, Ram. Nice
Deepak,
to
sir,
see you after so
welcome
much.
again, sir. Welcome again,
Thank
sir.
you. So slides are visible?
Yeah, they are visible, Deepak.
Okay. Okay, so the today's session is on bevacizumab plus atezolizumab combination in hepatocellular carcinoma. Just a moment. Yeah. So BCLC and ESMO guidelines for treating unresectable HCC both recommend atezolizumab plus bevacizumab along with or durvalumab plus tremelimumab in BCLC guidelines. And if it is not feasible, then sorafenib, lenvatinib, or single agent durvalumab is also an acceptable choice. Second line treatment options are regorafenib, cabozantinib, or ramucirumab in patient with AFP more than 400. If it is not feasible, then patient should be considered for clinical trial. And third line cabozantinib is recommended. And if it is not feasible, then go for clinical trial. Similar guidelines are provided by ESMO also. And so the treatment goals by stage of hepatocellular carcinoma. So in stage intermediate BCLC B stage, there is still an option of loco-regional therapy like TACE or sandwich treatment with TACE and lenvatinib. If it is refractory, then we can move on to systemic therapy. Or in advanced BCLC C stage, systemic therapy is the only treatment option in which atezo plus bevacizumab or durva plus tremelimumab can be used interchangeably, and followed by second line option of lenvatinib or sorafenib, and third line treatment option of cabozantinib or regorafenib or nivo-ipi. So treatment goal of BCLC B stage is tumor shrinkage and necrosis and leading to cure by combination of systemic therapy and LRT. While in BCLC-C, the treatment goal is prolongation of OS by multiple lines of treatment while maintaining the liver reserve. So these are the recent, these are the phase 3 trial on which the various drugs are approved. So timeline shows that SHARP was the first trial for sorafenib, followed by lenvatinib on the basis of REFLECT trial. Then this atezo combination was approved on the basis of IMBRAVE 150 2020. Then checkmate nivolumab was approved, which is again then now withdrawn, and then Himalaya trial, which is tried regimen. It came in 2023. And 2024, the checkmate 90W, which is nivo plus EP combination. In addition, there is Emerald trial, Launch trial, and Leap trial, which are the TASTE, which include TASTE along with systemic therapy. So IMBRAVE 150 was a phase 3 study for efficacy, unresectable HCC with no prior systemic therapy. BCLC B and C both were included, and child flu class A, ECOG PS 0 to 1. And patient with main portal vein tumor thrombosis were also included, which is VP4 category, randomized to atezo plus beva or sorafenib alone. So primary endpoint was OS, which is hazard ratio of 0.66. You can see median OS 19-month versus 13-month, and another primary endpoint of PFS with a hazard ratio of 0.65, 8.9-month, 6.9-month versus 4.3-month. Response rates are 30% with atezo combination versus 11%. CR was 8%, which is very good, and DCR was 74% versus 55%. So what is the prioritized requirement for first-line systemic therapy? So the prioritized requirement is wide benefit, which means high response rate and low progressive disease rate, leading to longer PFS and OS. And another priority is lesser toxicities, less grade 3 and 4 adverse event with preservation of liver function so that patient remains fit for subsequent therapies also. So if we compare the various IO data. So the first one is atezo combination with bevacizumab. You can see that 18-month the OS is 52% as compared to 40% with a delta of 12% and hazard ratio of 0.66. And if we talk about nivo EP with lenvatinib and sorafenib, then the hazard ratio is 0.79 and median OS is 36-month. 3-year OS is 38% versus 24%. The third combination of steroid regime, when compared with sorafenib, it leads to hazard ratio of 0.78 and median OS of 16.4 month versus 13.8 month. So best the hazard ratio is achieved by atezo plus bev combination. So three factors for tumor response for long-term survival are higher response rates, deep responses, and long responses. So atezo plus bev combination satisfies all three factors. In patient with varices, atezo plus bev demonstrate efficient efficacy benefit for over sorafenib. In this trial, 26% of patients in each arm had varices at baseline. So prior to enrollment in IMBRAVE 150, esophageal varices were assessed and treated as per local standard of care. But there were some centers where these varices were not treated prior to receiving atezo plus bev. So if we compare the outcome of those patients with varices, so on the left-hand side, the table is for patient with varices. You can see that median OS and PFS is significantly better as compared to sorafenib. So OS is 17.7 versus 8.6 with a hazard ratio of 0.55. And PFS is 7 month versus 4.2 month and hazard ratio is again 0.55. Response rates is 30% and 17%. And when we see in patient without varices, again, there are hazard ratio of 0.72 and 0.67 for OS and PFS respectively with a similar response rates. So management of varices in patients prior to systemic therapy. So optimal treatment of large varices prior to atezo plus bev is unknown. Although the guideline recommend that at least one session of bending should be done. And patient with recent GI bleed within 6 months and those with high risk of bleeding on duodenoscopy or gastroscopy should have varices adequately treated prior to atezo plus bevacizumab initiation. So this is the first global observational registry of Tecentriq plus atezolizumab in Tecentriq plus Avastin in routine clinical practice, including from USA, Europe, and Asia. Various sites with study population of 433 patients. Out of these, 296 patients were eligible. Primary objective was describe the uptake of atezo plus bev in multinational registry and study the clinical or pathological traits associated with prognosis. So this real world study also shows the efficacy was as good as those that shown in IMBRAVE 150. The median OS was 15.7 months in this real world study, and median PFS was 6.9 months, which more or less matches with the IMBRAVE study. This is the data from the real world study of Taiwan, which shows that long-term survival outcome of A plus T, and 54 patient study with 90% of male. Hepatitis B was the cause in 68% and hepatitis C in 18%. Median follow-up 79 months. Median OS was 19.6 months, which is again matching with the IMBRAVE study. And oral response rate was 34%. You can see the right side curve, blue curve is overall survival. So at 5 years, OS rate is 19%, means approximately 1/5 of patient was still surviving at 5 years. And if we see the OS by treatment response, those patients has CR or PR, they have highest response, highest survival rates at 5 years. 47% patient were surviving, which is a very good survival rate. So from data collected in 4 medical centers in Taiwan, A plus T led to a notable proportion of patients achieving long-term survival with a 60-month OS of 19%. So in subgroup analysis, VP4 categories were also included in this study, which is, we all know that VP4 category is the worst prognosis subgroup, very short survival irrespective of therapy. So in this study, although other IO studies did not include VP4 population, but in this study they were included. So in this study, those patients had VP4 category. The median OS was 7.6 months with atezo combination as compared to 5.5 months with sorafenib. Median PFS also was better than sorafenib, 5.4 months versus 2.8 months. Response rates were also very good, 23%, only 13% with sorafenib, and treatment-related adverse event were lesser than the sorafenib. So this VP4 subpopulation, which is considered very poor prognostic subgroup, can also be well treated with this atezo combination. So patient quality of life and liver function well correlate with prognosis, and they enable the patient for further subsequent treatment. So subsequent therapy rates with atezo and bev era. So preserved liver function by atezo and bev provides highest rate of subsequent therapy. More than 70% of patients are eligible for second-line treatment. And like Korean real-world study, 66% of patients, and in Japanese real-world study, 88% of patients were eligible for subsequent treatment because of preserved liver function. This is the Indian real-world study from Kerala and another study from AIG. So these are all retrospective studies with multicentric involvement, and total patients were 104 and 67. And common comorbidities were cirrhosis, diabetes mellitus, which is also a very good poor prognostic factor for HCC, hypertension in both studies. Etiology of liver disease was alcohol in 50% of patients in Kerala study and NASH in AIG study. So BCLC stage most common was C, which is seen in 58% and 74%. Similar treatment of atezo plus bev every 3 weeks in both these studies. Median OS was 14.8 months in Kerala study and 12 months in AIG study. Median PFS was 6.2 months and 8 months. Childhood A category has highest survival of 19.5 months and 21 months, and PFS also 6.3 months and 18 months. Overall response rates were more or less similar in both the studies, 33% and 38%. Most common grade, any grade adverse event was fatigue in both the arms. Incidence of grade 3 or more adverse event was 10% and 21%. And reason for drug discontinuation due to adverse event was 8 patients or 45% of patient because of liver dysfunction, disease progression, or bleeding ascites.
Sir, please conclude in 2 minutes.
Last slide. So in conclusion, these results suggest that atezolizumab plus bevacizumab is a good option for patient with untreated HCC with overall response rates of 33% and DCR of 63%. Survival and response to therapy depend upon the severity of liver disease. Well-selected patient like Childhood A, ALBI grade 1 and good performance status had better PFS and OS similar to the results of clinical trial. Although a considerable number of patients do not meet the trial criteria, immune checkpoint inhibitor therapy is generally well tolerated, with only a small percentage of patients needing to stop treatment due to adverse effect associated with immunotherapy. Thank you. That's all from my side.
Thank you, Deepak Gupta, sir. Just one and two quick questions from my side, sir. Sir, like I have a patient in my clinic, HCC hepatitis B positive, and patient, sir, are you there?
Yes, yes, I am here.
Yeah. So, but sir, the patient platelet is around 70 to 80,000 because he's having CLD also. So, do you think, sir, that in these kind of patient with the performance status 2, CLD, alcoholic, hepatitis positive, platelet 70,000, do you have any hesitancy of using BEV or are you comfortable with it, sir?
No, I think thrombocytopenia, we should avoid BEV. It may lead
Okay.
to bleeding complications.
Okay, sir. So even if the patient has CLD de novo and platelets are low, you will like to avoid. So you all like to go with the lenvatinib, sir, or want to go with any single agent IO? Like what will be your choice, sir, for these kind of
No,
patients?
we can use the IO plus any TKI, or you can go
Okay,
for that durvalumab based combination, which is safer,
okay. Thank
tried
you, sir.
regime. Yeah.
Yeah, absolutely, yes, sir. Absolutely, yes, sir. Ram, sir, are you there, sir?
Yeah, I am here only. So,
Okay.
Deepak, it was a nice insight. But what I will like to add on that what I've seen in my practice that most of you oncophysicians forget the role of other ablation procedure in these patients. Many of these tumors can also be, say, treated along with chemotherapy or immunotherapy or these therapies. I think TAEs or microwave ablations or RFA ablation, they can be added to many of these patients. But somehow I feel that many of these patients are neglected, and these simple things like microwave ablation or RFA are missed in many of these patients. So what I will like to say that I will request to my all of guest physician, onco physician colleague that you should also give good insight into the radiology of the tumor. And if feasible, I think then the microwave ablation or RFA should be offered to most of these patients along with chemotherapy. So this
So
is what
Ram,
I
in
like to say.
Ram, in BCLC B stages, there are data for TACE plus systemic therapy
Yeah,
combination.
yeah. Yeah,
Yeah.
yeah, please go ahead.
But because the issue is that we don't receive such patients too frequently. Most of the patients
Yeah,
are either
end stage.
BCLC
Yeah.
C or very poor
Yeah,
performance
yeah,
status.
I do accept many of these patients present with total vein thrombosis and all other risk factors as well. So
Yeah,
yeah, I do agree. But there are some selected patients where we can use these adjuvant therapy along with chemotherapy, and we should not miss that opportunity. In fact, in these patients.
definitely yes.
Thank you. So,
Thank you, Deepak again.
thank you, Deepak Gupta sir, once again, and thank you, Dr. Ram Daga sir, for chairing this wonderful GI session. And hope to see you and interact with you in further conferences also, sir, to take your expert insight. Thank you
Thank you,
so
Dr.
much, sir.
Deepak.
Thank you. So, we are moving ahead to our last session of hematology. And we have two sessions. The first with Dr. Abhishek Charan and next with Dr. Vishnu Sharma sir. So for the next session, I would like to welcome Dr. Abhishek Charan. Dr. Abhishek Charan is one of the most dynamic medical oncologists in Jaipur, highly in demand. Abhishek, are you there? Good evening, dear.
Sorry, sir. You have
So
really put
Abhishek is
so
right
high notes.
now like a great star in Jaipur and Rajasthan. And
Sorry,
Abhishek,
sir.
and thank you so much for joining, dear, and
Thank you.
welcome you for the
Thank you so
session.
much,
He's
sir,
going to
for
speak on teclistamab in early relapse and refractory multiple myeloma, a game
mm,
changer with transformative evidence. Over to you, Abhishek.
thank you, Pulkit boss, for nice word and opportunity to be part of this great webinar. And I have
Yeah,
learned a lot in last 30 minutes from this webinar. So
thank you.
without wasting further time, as we are already delayed by 9 minutes, I'll not waste much time. So we'll go with the slide. And the topic allotted to me today is the teclistamab. It is the one new, I mean, new agent which we are using in multiple myeloma. I have personally used it, and it's showing quite dramatic result in those penta-refractory patient. So can we have the slides, please? Yeah, can we move? Yeah. So coming to the teclistamab, it is a new agent which is mainly a first-in-class off-cell T-cell redirected bispecific antibody. So it has a dual action. It targets your BCMA on myeloma cell. Along with that, it targets CD3 on T cell. So it binds to both of them. So by binding to CD3 on T cell, it activates your T cell, and then that cascade reflex activates, and your cytokine release will be there. Your perforin granzyme will be reactivated, and patient will have a cytokine storm in some of the cases. So there is saying that it may lead to CRS in up to 10 to 20% of the patient. Though tocilizumab is indicated as a treatment and has been tried as a prophylaxis also in few cases, but not in all cases. So this is a new agent which is a humanized IgG4 bispecific or antibody that target both CD3 as well as T cell also on T cell and BCMA on myeloma cell. And teclistamab is generally used DuoBody platform, a validated versatile platform from which it has been generated. Next, please. So it is administered through personalized weight-based body, and it is generally given as subcutaneous dose because it has a high risk of CRS, ICANS, other toxicity, and cytokine storm. So prophylaxis and your pre-medication is very much part of it, and because of the risk of CRS, it is generally scale-up dose is given. So in patient who, and it is generally, we generally start with 0.06 mg per kg on day one, then escalated to zero point 0.3 if there is no side effect, and then we reach to its potential and optimal dose, which is 1.5 mg per kg. If we achieve a CR within 6 months, and it has been durable for lasting more than 6 months, then this teclistamab can be given fortnightly also. Otherwise, it has to be given weekly regimen. So the CRS risk is generally seen in first few doses. So if you haven't encountered in first 4 to 5 doses, it is rare to see CRS further or any sort of toxicity, ICANS or such. So it is generally given as a scale-up dose, and due to risk of, and mainly due to risk of CRS, it is considered like this. Next, please. So what are, and as I already mentioned, it is a subcutaneous, so it can be given as outpatient department on OPD basis also. Though I administered in our patient and two patient, admitted the patient because one of the patient was on Dara plus teclistamab. So I was a bit concerned that patient may have CRS because of the dual. But otherwise, it is quite safe to administer. It can be given in the OPD or daycare basis. And what has to be looked into, the patient should be good performance status, disease burden, and your pre-chemo and all that profile, and your organ should be preserved, ECG, echo, and basic your blood parameters should be normal, and then patient can be administered teclistamab with the proper prophylaxis in the OPD basis also. Next, please. So before initiation treatment, what has to be seen? The condition of the patient, as I already mentioned, and the side effect. What has to be before giving? It's basic. You have to give Dexa, acetaminophen, and Rentec, and this as a prophylaxis. But what comes after that is even more concerned. Whether patient will have immediate side effect? No, I haven't encountered yet. And as per the data, also in the Majestic 1, 2, 3. Immediate side effects are quite rare. Drug reaction are also almost next to zero. But patient will have CRS. Some sort of CRS will be there. So what in our experience in two patient, what I have seen, the patient developed fever and fatigue, and patient had headache. So I even suspected it may be ICANS also. So we suspected ICANS and we worked up on ICANS line also, though it was negative our workup. So because of that, CRS grade 1 was quite common in patient, in both teclistamab patient what I've encountered, and it is quite common. So some sort of side effect will be there. Most common is CRS. It will not be immediate. It will be seen in day 2 to day 7, most likely, as we see in CAR-T or other monoclonal antibodies or other, but it can be seen. So other than that, other side effect which can be was is fatigue, headache, diarrhea, or myelosuppression. These are the common side effect. Patient will have thrombosis, also bleeding tendency will also be there. But most common side effect will be your CRS, and which will be seen almost all patient, but mostly will have grade 1 or 2. So next, please. So teclistamab can be restarted after prolonged interruption. So there were studies when teclistamab was given, patient was taken on transplant, or patient discontinued because he had a good response CR, and then eventually patient completed 2 years or 3 years of teclistamab and patient was stopped. So what is seen in the pharmacokinetics is that drug concentration is maintained till 62 days. So we don't need the scale up dose if we reintroduce the drug after 62 days. So up till 62 days, your drug level are maintained. So beyond that, you need to escalate the dose, and again you have to start the procedure from baseline, because then it will be there will be risk of CRS. So this is quite good that drug concentration lasts up to 62 days. So it has a long prolonged action also. Next, please. So teclistamab is a first class of the shell T cell redirected therapy with a convenient subcutaneous doses. So it is designed for BCMA cells which are present on myeloma, and it is administered or personalized weight-based dosing. Teclistamab can be restarted after prolonged treatment interaction with minimal risk of CRS. CR, if patient has CR for more than 6 months, then it can be given fortnightly at the optimal dose of 1.5 mg. And if in case if patient has less frequent dosing is required, if patient lives far away, then in those cases it can be given monthly also with a dose of 3 mg per kg. Next, please. So in the Majestic 1 trial, which formed the basis of the approval for teclistamab in myeloma, and so penta-refractory cases, those who have been exposed to two IMiDs, to proteasome inhibitor, and your CD38 DARA. So in those cases, penta-refractory, post 3 lines, if we introduce Majestic, if we see this trial, and if a patient was given chemo or other standard of care, the duration of response, your deeper response, and even your overall response and everything was far better as compared to your standard of care arm. And in this study, it was seen deeper the response, and then it will be proportional to your duration of response. If we get CR, if we get VGPR, the duration of response will be better as compared to your partial response or stable disease. So this has been seen, and you can see in this graph duration of response and PFS also. Almost 50% of the patient had PFS around 18 months also. So that shows the result was quite good. And same was seen in the overall response. Almost 46% patient achieved CR. That's quite good result, keeping in the mind these patients are heavily treated post 3 to 4 lines, and they have been exposed to more than 5 to 7 drugs. Next, please. So as I already mentioned, CR rate in this trial was 46 and VGPR was even better, 63. But what we are concerned, CR is quite good. The more the CR, the more it will be your duration of response, as already. And this was studied in Majestic 1, another Chinese cohort, and another study. So this has been a universal, observation that better the response, deeper the response, the longer it will be. Next, please. So post hoc analysis of Majestic 1 showed the median PFS, median OS, and median duration of response were prolonged compared with overall Majestic 1 analysis, with a when patient who died from COVID-19 were censored from it. So in this, it was found that post 3 lines, median PFS was almost 15 months. That's quite good. And median OS was almost it was seen that median OS also lasted for almost 18 months. So that shows quite good. Next, please. So the quality of life was also not hampered, and side effects were quite manageable. Initially, patient within 15 to 20 days, patient will have some botheration and will have side effects, severe headache, fatigue, myalgia, arthralgia, diarrhea, all sort of side effects may come on, but most of them are manageable. Dose reduction or dose interruption was seen in less than 10% of the patient. So quality of life was maintained in a good way. Next, please. So in Majestic 1, teclistamab demonstrated an overall response rate of 63%, out of which CR was seen in 46% of the patient, with deep and durable response, though 2.5 year of follow-up in these patients were seen. And at the median follow-up 2.5, I mean, this is quite good. Median PFS and median OS was not even reached in patient who achieved CR. Teclistamab demonstrated deep and durable response in a diverse cohort also. Post hoc analysis showed median PFS, OS, and median duration of response were prolonged. And it was reported that quality of life was also quite good, especially in those patients who achieved a better response, good response, such as CR. Next, please. So, result from one more trial, locomotion trial study, also demonstrated that the 2.5 3 times more likely to reach overall response rate as compared to your standard of care, and this showed a better significant improvement in your duration of response and PFS. So, next, please. So this graph of PFS, overall survival duration of response, almost goes similar as per your Majestic 1, and there is not much to difference in the median PFS OS, and they were good. And the basic is deeper the response you get, longer it will last. Next. So teclistamab demonstrated a substantial efficacy benefit versus the current of the shelf therapies for patient with TCA relapse myeloma. And result from this locomotion trial or even Majestic 1 confirmed that it will work better in penta-refractory cases if used post third line. It can be combined used as second line also if as per Majestic 2 basis if you combine Dara plus teclistamab, that also has a study. Next, please. Next slide. So discussion, yeah. So this shows overall response rate if we go in a penta-refractory. So patient, those who had high risk cytogenetics or those who have age 75 and had response rate that were comparable with the overall population. So as you can see in the refractory, penta-refractory, more or less the graph shows even in the high risk category, high risk cytogenetic, 36% of the patient had CR. And even in the elderly, the rate was almost 36, 70, 40 in most of the penta-refractory high risk or even the elderly patient. But it even in extramedullary disease or even those who have been, I mean, exposed, who have a plasma cell leukemia and anything, in those cases also it can be used. But in that response rate will be somewhat less as compared to your frank myeloma who has been refractory for long time. Next, please. So in heavily pretreated patient, those who have been with prior exposure to BCMA targeted therapy, teclistamab can be used, and it showed a promising overall response, median PFS and median OS response, and response occurred even early, deepened over time, and they were also durable. So this study showed that median PFS was 4.5 months. These patients are mainly those who have already been exposed to BCMA targeted therapy, and again the different BCMA target therapy was used, and so even this can be used if patients are out of the choice and if they don't have other option and if they were not exposed to teclistamab. Median OS in these patients were around 15.5 months. Next,
Sir,
please.
please conclude in 2 minutes.
Yeah, next, please. So, what line of treatment will use teclistamab? Mostly, it can be given after third line, post 3 lines of exposure. And if we see Majestic 2, it can be given Dara plus Tecli as a second line post your refractory relapse in second line also. Next, please. Yeah, already covered. Next, please. So teclistamab has demonstrated efficacy across patient subgroup, including high-risk patient who have received prior BCMA therapy, and patient who are refractory relapse. So Majestic 1 has already showed these results. Locomotion trial and other trials also showed the same result. Next, please. So with median follow-up of almost 2.5 year, teclistamab remained well tolerated, and the rate of discontinuation due to A were very less. The side effects were quite manageable. CRS will be there, cytopenia, infection will be there. IVIG may be required as prophylaxis. I've also administered IVIG as prophylaxis in most of the patient, in both my patient. And uh, doc- uh, tocilizumab I did not use, though I used in one of the patient as a therapeutic, but not as a prophylaxis. So it can be used. I mean, IVIG should be given because there is a high risk of infection. The patient will have some sort of infection, fungal or something. So that has to be kept in mind. Next, please. CRS rate already I've covered that most of the CRS will be grade 1 and 2, and almost 3 and 4 will be next to, I mean, but very less at 1 to 2% patient. 80% of the patient will have CRS, and it was manageable with either symptomatic treatment, steroid, or some cases tocilizumab may be required. Next, please. So overall response rate already covers 46% of the patient will have a good CR, and side effects were quite manageable. Infection was there and it was seen 45% of the patient will have the infection. Next, please. ICANS was quite less. ICANS as observed because of the size and because of the penetration, because patient will not have the disease in the brain in myeloma patient. ICANS was seen quite less. Next, please. Yeah, already covered. Infection will be there, and we need to give prophylaxis of Septran and antifungal. It may be required if a steroid was administered. So Septran acyclovir prophylaxis should be given if teclistamab was given. In some time, antibiotic prophylaxis may be required if patient is having grade 3 neutropenia also. Next, please.
Abhishek, can you conclude here?
Yeah. Next, please. Come to the next slide. Conclusion one. Yeah. So coming to the summary, that this is a BCMA targeted therapy, which is a new drug. It is coming up with a now with the many multiple myeloma patient as it is available widely. It has shown quite a good result, and it the safety prophylaxis is quite good because it is given subcutaneously, and I think it will come even more as the cost comes down. That's it from my side. Thank you, sir.
Thank you, Abhishek, for sharing this the wonderful data. I think you are one of the few oncologists in Rajasthan using Teclistamab, and that shows your great gist. Dr. Vishnu Sharma, sir, welcome, sir. Good evening. And
Thank you.
anything you want to comment or ask Dr. Abhishek Charan regarding Teclistamab? Abhishek, are you there? Abhishek?
Yes, sir.
Yeah, Vishnu Sharma, sir, anything you want to comment or ask Dr. Abhishek regarding
How
Teclistamab?
how do you sequence these drugs? Because we have multiple bispecific CAR T cell therapies for myeloma. So how do you sequence these drugs, especially for patients who are relapsing
Sir,
post-transplant, post-DARA?
post Dara, sir, if patient is affordable, in that case, I've counseled two patient for CAR-T also for myeloma. I've referred them to Bombay also. So CAR-T will be my first choice if patient has relapse refractory, post penta refractory. But in case CAR-T is not eligible or patient is not having affordability, in that case, if patient has logistic, then I'm advising teclistamab. And even if those patients who have already been exposed to DARA, as per Majestic 2 trial, because DARA will work as a sensitizer for your teclistamab. It will give the I mean release of the T cell will be more there. So even those who have been exposed to DARA, and if there is a window of 6 months or so, I'm combining DARA plus teclistamab also. At least as a first, I think BCMA, which I'll prefer over the other two, which are also available in the market. And if not, then we are going for the chemo only. And if patient had a good, I mean, PFS of 2 years post transplant, then I am offering transplant also to few of the patients.
How do you see performance status making difference while choosing CAR T over this teclistamab or teclistamab over CAR T?
Sir,
Patient.
I feel for CAR-T at least PS should be, I mean, better and disease low. but for checklist single agent, I feel PS2 is good enough. We can administer. And it is very convenient, at least for first two doses. Then it is very smooth to administer this drug because side effect and everything is quite manageable on OPD basis also.
So actually, this is a wonderful drug for patients who are having borderline performance status, not fit for CAR T cell therapy, because myeloma is a.
Yes, sir. I agree.
Yeah.
I agree.
Thank you.
Thank you, Dr. Abhishek,
Yeah.
for the wonderful presentation.
Thank you, sir.
And now I would like to mention, welcome Dr. Vishnu Sharma, sir. Sir, good evening and welcome, and thank you for taking out time. And we are
Good evening.
coming to the last presentation from your side, sir, though very important. So, sir is working as a professor in prestigious SMS Hospital and Medical College in Clinical Hematology Department. And sir will be speaking on optimizing first-line therapy in newly diagnosed CML accelerated phase, case-based approach. Over to you, Vishnu Sharma, sir.
Thank you, Dr. Pulkit, for your wonderful words and introduction.
Thank you, sir.
So,
You will be sharing the slides, sir?
I'm trying to share from my end. So,
Sir, do you want organizers to share the screen if you are comfortable?
please share from your side. I'm unable to
Tech
actually.
team, please share the slide, please. Sir, you have to stop screen sharing then.
Okay.
Sir, the screen is visible.
Yeah. Can you see slides from my side or?
Now are you able to see the slides, sir?
Yes,
Yeah,
sir.
yes. And slides are moving also, no?
Just go to next slide, sir.
Okay. Just 1 second.
Sir, actually, I'm sharing a slide.
I have started sharing. Is it visible to you or not?
No, sir. The technical team has shared the slides. So you just tell them to move ahead. They'll move as the next slide possible. Just tell them to move to the next slide, sir.
Okay. So actually, slide is not visible to me.
Sir, I think now you have
Sir, now your
shared.
screen is visible.
No. Slides are not visible to me.
Sir, your slides are visible. Now you can go ahead.
Slides are not visible to me actually. I cannot see slides.
Sir, can you just
Sir,
stop?
we can see your screen, sir.
So my screen is so.
Yes, it is visible to us.
Slides are visible to you.
Yes, sir. Yes, sir.
And slides are moving, right?
Yes, sir. Yes, sir.
Yes, sir. It is moving, sir. It is moving.
So yeah. So I'll be speaking on optimizing first-line therapy in newly diagnosed CML-CP, a case-based approach. So this is what is sponsored session. So first of all, I'll be starting with a hypothetical case. Young female, 28-year-old software engineer by occupation, recently married and planning for pregnancy in next 2-3 years with no comorbidities, with incidental finding of elevated CBC, with the TLC of 85,000, normal hemoglobin, normal platelet count, peripheral smear showing the left shift with basophilia, mild splenomegaly, 2 centimeter below costal margin. So incidental diagnosis in a young patient, otherwise healthy women. The treatment decision made today will impact the next 30 years of her life. So bone marrow revealed hypercellular marrow with less than 5% blast. Cytogenetics revealed translocation 922 with positivity for BCR-ABL, 968%, and low risk disease, low risk ELTS. There was no comorbidities, ECG, echo, LFT, KFT, everything was normal. So what matters to this patient? There are certain considerations while selecting TKI, especially for young patients. So for this patient, long-term safety is of paramount importance because he has to take treatment for long term. At the same time, she'll be planning for pregnancy in the coming future. So we need deep and fast response to plan for pregnancy. And she's a active career professional, so she cannot tolerate debilitating side effects like myalgia, muscle pain, and fatigue. And it is a low risk disease, so we want best chance for deepest possible response along with treatment free remission with acceptable quality of life to improve the adherence. So multiple factors should be taken into consideration while selecting TKI. Some factors are determined by the patient factors like age, risk factors, patient preference, ability to tolerate therapy. Some treatment-related factors like comorbidities, drug interaction, TKI toxicity profile. According to the 2020 ELN criteria, the EMR is defined as less than 10% BCR-ABL at 3 months. So these are the optimal responses of BCR-ABL response assessment. At 6 months, less than 1%, 12 months should be less than 0.1%, also known as MMR, and it should be less than 0.01% at any time point. And there are multiple objectives which were important for every patient. Like the most important is achievement of the deepest possible response or DMR, followed by prolonged overall survival and achievement of early molecular response, because it has been found that early molecular response is associated with durable overall survival, and achieving both early molecular response and stable deep molecular response are associated with low risk of loss of response and TKI resistance, and are crucial for patient considering discontinuation of TKI. So this is most relevant for this patient. So there are unmet needs in first line CML because the most newly diagnosed patient do not achieve major molecular response by 1 year or deep molecular response by 2 year. So patient, almost 2/3 patient failed to achieve major molecular response by 1 year with imatinib, and over 50% patient failed to achieve the major molecular response by 1 year. And at 2 year time point, the MR4, 73.4% patient failed to achieve MR4 at 2 year with imatinib, and 65.7% patient failed to achieve MR4 at 2 year time point. And MR 4.5, almost 85% patient did not achieve MR 4.5 with imatinib, and almost 80% patient failed to achieve MR 4.5 with 2G TKI. So significant number of patients failed to achieve the MMR or deep molecular response at 1 year and 2 year time point. TKI intolerance can cause intentional non-adherence, and it has been stated in various studies. Patient who remain adherence, that is adherence more than 90%, the chances of achieving CMR at 6 years is 43.8%, major molecular response 76%, and the MR4 is 76%, and MMR is 94%, 93.7%. And patient with less than 90% adherence, the CMR, MR4, and MMR rates were quite dismal. MR4 only 4.3%, MMR at 6 year 13.9%. So treatment adherence is very much important, and it is important to choose TKI which improve the treatment adherence. So patients with higher adherence are more likely to achieve deeper response and will be eligible for TFR. So intolerability can prevent patient from meeting their treatment goals because the treatment related adverse events can affect the adherence, and it can lead because of reduced quality of life, suboptimal dosing, non-adherence, treatment discontinuation, switching therapy. So So these patients, because of the multiple side effects, the adherence will be affected. Limitation of existing TKI for this patient. Why conventional TKI may fall short? Because there are many side effects which are associated with the currently available TKIs. For example, imatinib, the limitations are slower, deeper molecular response, fluid retention, fatigue, muscle cramps, delayed TFR window. Dasatinib, pleural fusion, which is very common, reported almost in 30% of patients. Patient can develop pulmonary arterial hypertension, QT prolongation. Nilotinib, arterial disease can develop cardiovascular risk factors. It can cause cardiovascular disorders, metabolic disturbances like hypercholesterolemia or diabetes, QTC prolongation, and it requires fasting. Bosutinib, significant GI toxicity, hepatotoxicity, and impacts daily functioning. So each conventional TKI carries at least one long-term risk that is implied over 30 years of therapy in a young patient. So it is important to choose TKI based on the side effect profile. So why asciminib for this patient? Because of these 5 regions, fastest path to deep molecular response. So it opens the window of TFR at earliest possible time point, best in class tolerability, which supports the lifelong adherence. There is no cardiovascular side effects, metabolic disturbances, QTC prolongation, or pleural effusion with asciminib. Pregnancy compatible strategies, because we can achieve deep molecular response and treatment free remission can be achieved early, and quality of life can be preserved, especially for young patient like this patient. So coming to the asciminib, so it has a different mechanism of action. It acts by targeting myristoyl pocket of ABL1, which is fundamentally different from the ATP competitive TKI. So it binds with the myristoyl pocket of the ABL1 kinase, and it restores the inactive state of BCR-ABL1 by binding with the myristoyl pocket. So binding site is different from the conventional TKI. So it can be used in combination with TKI also, and it can be used in patients who are resistant to TKI because of TKD mutations. Coming to the S4 first trial, where asciminib was used in the frontline setting in CML-CP patients. So major molecular response rate at week 48 was superior with asciminib versus all TKI and versus the imatinib. So if you see in the left hand side bar diagram, with asciminib, the major molecular response was 67.7%. So close to 68% major molecular response at 48 week. When it compared with the investigator selected TKI, it was 49%. So almost 19% superiority of asciminib compared to investigator selected TKI. And this difference is even more significant when it compared with the imatinib. So it was 69.3% with asciminib compared to 40.2% with imatinib, and overall the difference was close to 30%. Deep molecular response rates were also superior at 96 weeks time point with asciminib compared to the all available TKI. So with asciminib, the MR4 was 48.8% versus 27.5% with all investigator selected TKI. The MR 4.5 was 30.9% with asciminib compared to 17.7% with the investigator selected TKI. When it compared with the imatinib, it was 52.48% with asciminib, 23.5% with imatinib. So more than twice difference the response, deep molecular response with asciminib. And when it comes to the MR 4.5, it was 35.64% compared to 11.76% with imatinib. With 2G TKI also, difference is significant, 45% with asciminib compared to 31.4% with 2G TKI. MR4 and MR 4.5 was also significantly higher with asciminib. So when it comes to the early molecular response, so early molecular response is an independent, the prognostic indicator of oral survival in CML. So it was close to 90% with asciminib compared to 70% with investigator selected TKI. When it comes to the imatinib, the difference is even more remarkable. It was 88% with asciminib compared to 60% with 88% with asciminib compared to the 60% with imatinib, and difference is there with 2G also. So asciminib is generally a favorable tolerability profile. So treatment discontinuation rate was also less with asciminib because of adverse events. So more patients remained on therapy at week 96 with asciminib. 81.6% patient remained on therapy at week 96 compared to imatinib only 52%. 2G it was around 68.7%. And fewer patients on asciminib discontinued treatment because of adverse events. Only 5% patient continued in asciminib compared to 13.1% discontinuation of imatinib and 12.7% discontinuation of 2G. A lower rate of dose adjustment or interruptions were needed with asciminib because of adverse events. So it was 33% with asciminib compared to almost 42% with imatinib and 58% with 2G. So this shows the better tolerability and treatment adherence with the asciminib. When it comes to the time of treatment discontinuation due to adverse events, it was the discontinuation rate was more with nilotinib compared to asciminib, and this is beautifully highlighted in this diagram that the asciminib continued to demonstrate superior tolerability when it compares to the nilotinib. Safety advantages. So there is no concern of pleural effusion with asciminib, which is significantly there with dasatinib. Cardiovascular risk and arterial obstructive diseases was not there with asciminib, which is a significant risk with nilotinib. QTC prolongation is not a concern with asciminib, and it is reported with dasatinib and nilotinib. GI toxicity is very minimal with asciminib compared to, which is like very significant with bosutinib, and it is there with imatinib also. Fluid retention is very common with imatinib, or rather it is one of the commonest side effect of imatinib. And with asciminib, it is very less. Musculoskeletal pain and other symptoms were very low with asciminib, and it is very significant with imatinib. So for a 28-year-old female, asciminib robust safety profile is decisive advantage. So multiple advantages are there with asciminib because of the free from these significant side effects. So to summarize, despite treatment advances, unmet needs persist, and treatment that optimize tolerability and efficacy are needed. Treatment switching is frequent with the ATP competitive TKI, including imatinib, dasatinib, and nilotinib. Results of the S4 first found that asciminib MMR rate was superior over the available standard of care TKI at week 48, and effect that was continued at week 96. So this shows the efficacy of asciminib and the early and deep molecular response with asciminib. Patient receiving asciminib were also observed to have greater rates of deep molecular response when compared to the standard of care TKI, and this effect is persistent with 2G TKI also. In S4 first trial at week 96, more patients remained on asciminib and fewer on asciminib discontinued due to adverse events, and lower rates of dose adjustment or interruptions due to adverse events were also seen. So this shows the safety of asciminib. With this, I thank you organizers for giving me this opportunity. Thank you.
Thank you,
Thank
sir.
you, sir.
Thank you for the excellent talk. And I
Yeah,
would request Dr. Pulkit for
yeah,
the
yeah.
closing remarks.
Sir, thank you so much. I just have one quick question for you, sir. Like,
Yes.
do you use the full dosing in de novo CML? And what is the dosing you use in the second or third line setting? And do you have to go with the dose interruptions in second line setting? Yeah.
See, the dose for like upfront dose is same. Uh, uh, like someone who failed 2 or more than 2 TKI, the dose is 40 milligram BD or 80
Yeah.
milligram once in a day. So it can be given once in a day also 80 milligram. It is different for T315I. So it is 200 milligram
Yes.
5 times, 200 milligram BD. But for
Yeah.
upfront setting, it is same 40 milligram BD or 80 milligram once in a day. And for 2+ line failure, the dose is same, 80 milligram OD or 40 milligram BD.
So for T315I, sir, like when you use the full dose, almost 5 tablets of 40 mg.
So whether you need see the patient having some complication or side effect, or patient is easily tolerable on the full dose, sir?
Oh, it is very well tolerable drug. So
Great.
tolerability is, I can say, better than imatinib, even
Wow.
at 5 times dose,
Wow.
like 100 milligram BD. So I have
Great,
four
sir.
patients who are like taking
Superb.
200 BD with 23315I.
Thank you so much, sir, once again. And looking forward more to the discussions in future, sir. And thank you
Thank
again, sir.
you.
Thank you. Good night, sir.
Thank you.
Good night. Good night. So I think we have come to the end of this wonderful 2-day webinar. And I think I would like to thanks to the organizing team. Tarunji, are you there?
Yes, sir, he is there.
Yeah, yeah. So thank you to the whole team. I think it was very well organized, and we well finished in time today. And I would like to thank all the faculty members and all the participants who have made this webinar so academically wonderful and so knowledgeable. Also, I would like to thank all the academic partners, that is AstraZeneca, Roche, Dr. Reddy, Natco, Johnson and Johnson, GSK, Pfizer, Novartis, Lupin Oncology, Astellas, Intas, Merck, and Zydus. And wonderful. I think we'll keep on discussing such great topics, such academic topics in future also. So thank you once again to the whole organizing team.
Thank you, Dr. Pulkit sir, for giving this opportunity on behalf of my team, Ekta, Daud, and Pooja. So thank you so much. Stay safe, stay blessed till we meet again, and good night from all of us.
Thank you. Thank you so much. Good
So
night. Thank
technically.